Professor Hankir,
Hello.
thank you so much for coming in. I know you've been just coming from Canada and you're coming in,
Literally, right?
yeah, and I felt kind of bad dragging you kind of, in to do this podcast, but I really appreciate it. Now, obviously you're a professor in psychiatry, and I don't normally go too much into introductions with people, but I think yours is so important because I think your upbringing has had such an impact on you and your profession. So I'd like to start with that, if that's okay.
Of course. Yes. So I'm Professor Ahmed Hankir. I'm a consultant psychiatrist. I live between the UK and Canada, and I visit England often. My research is on pioneering and evaluating innovative interventions that reject mental health related stigma. I'm honest, open, and transparent about my mental health experiences to reject stigma and debunk the many myths about persons living with a mental health condition that abound. For example, we have a proclivity for violence when the reality is that persons living with a mental health condition are far more likely to be the victims of violence as opposed to the perpetrators. And it has been a journey,
Yeah.
to say the least. I was born in Belfast, so my parents migrated from Beirut to Belfast in the 80s.
Wow.
And my mother, she continues to say that it was like jumping out of the frying pan and into the fire because there was a brutal conflict in Belfast at the time, the Troubles. Nonetheless, they moved to Belfast, which is where I was born, and there was a war taking place in Lebanon at the time. And I was raised in Dublin and then moved to England. And then when I was 12, I moved to Lebanon with my parents. And from 1995 to 2000, this was the aftermath of the civil war in Lebanon in the 80s. I was living in Lebanon, and then I moved to England when I was 17. I had to leave my parents behind me because the situation in Lebanon back then, the situation in Lebanon now isn't good, to say the least, but it wasn't good back then either. So came to England. My first job was working in a van selling burgers and kebabs for a living.
Wow.
Yeah, people would ask me if I could speak English. And here I am today, a World Health Organization award-winning psychiatrist. So it's been a journey.
Yeah, it's been an absolutely crazy journey. You don't have to go too much into this, but I think looking back on it now, reflecting on what happened, during your adolescence years, do you feel like that may have caused potentially you some mental health problems that you're still dealing with now?
Without a doubt. Yeah, definitely. Still processing that. There is so much unresolved trauma from my childhood, adolescence, and even throughout adulthood that I'm still processing. And it continues to influence my mental health, my interpersonal relationships, my functioning, even though I'm not conscious of it. And that's why I'm a big fan of psychotherapy, specifically psychodynamic psychotherapy, when we kind of delve into the unconscious and we try to process all that unresolved trauma that's just kind of lurking in the unconscious.
Yeah, I think it's interesting because a lot of people have these potentially triggers when they're younger that they grow up with that they don't necessarily know. And I think recently more so, we were saying off camera about the stigma of mental health has thankfully sort of lessened over the last few years.
We've made some progress, but there's still a lot of work to do for sure. Yeah, and don't forget the toxic masculinity.
Yeah, that thing is obviously big on social media at the moment. One thing I want to touch on was there's always been a massive spike in mental health. I've seen it in my own practice, in general practice, and obviously you as a psychiatrist would have seen it, much more. Obviously, I think I know one of the reasons is probably down to the lockdown.
Yeah, the pandemic. Yeah.
Pandemic, but why do you think there's been such a rise in across all pathologies, so depression, anxiety, whatever it might be?
Yeah.
And also from what you're seeing, why do you think there's been a rise, such a massive rise?
I think a major contributor would be the cost of living crisis. So we know about, the social determinants. For example, poverty, unemployment,
Mm.
accommodation insecurity,
Mm.
food insecurity. So these are all risk factors or vulnerability factors to developing common mental health problems like generalized anxiety disorder and major depressive disorder, which I know you see a lot of in primary care. But also, SMI, severe mental illness, bipolar affective disorder, and schizoaffective disorder, and schizophrenia. So for sure, these are the social determinants contributing to a rise in mental health problems. And like you said, the legacy of the COVID-19 pandemic, especially on younger people.
I think one of the most common ones I've seen is certainly around depression, which is great on one scale because it's raising awareness and people are coming out to seek help for depression. But I think also there's a risk of maybe labeling people with depression when they may not have it. Now, I think it's important to understand if you could just have some clarity around what is kind of the difference between just feeling low or sad to sort of clinical depression.
I think we have to be careful. I agree with you. Not to psychopathologize the expression of human emotion, because in many ways you could argue that sadness is normal, right? It's not necessarily a manifestation of a mental disorder if you are feeling melancholic. But there is a difference between feeling sad and major depressive disorder. And I agree with you, and I can't emphasize that enough. We have to be careful. I think of the 3Ds, right? You think about distress and dysfunction and danger. So if your symptoms are causing any impairment in your functioning, and that can be academic functioning, your grades can start to drop, start to plummet. It could be your occupational functioning. Your performance in the workplace, for example, is not as good as it usually is. And it can even be your social functioning, and you become increasingly withdrawn. And so that's the first D, the dysfunction, any impairment in your functioning, in the important areas of functioning. And any distress, I mean significant distress. And then when I talk about danger, we talk about any thoughts of harming yourself or ending your life. So sadness is one thing, but it's like, I'm sure you're the analogy, right? Like abdominal pain, you might have like an upset tummy, or that's one thing, but like a raging appendicitis that needs urgent surgical intervention is something else, right? So it's like a continuum, isn't it? And it goes back to what I'm saying, like those 3Ds. Are the symptoms severe enough to cause impairment in your functioning, dysfunction, significant distress, substantial distress, and danger, contemplating ending your life, for example?
It's interesting because I think the cause of depression there's been a lot of toing and throwing around it, and I think the initial kind of model was a lack of serotonin, kind of in the brain, because I think the main treatment is to kind of raise that, but I think that's been shown, well, actually some people still argue that that's the case, and it's a lot of people are taking time to kind of catch up on that. But what are your thoughts in terms of the actual chemical? Is there a chemical imbalance, or is it something way bigger than that?
Well, that's been debunked, hasn't it? And we are urged not to frame it as a chemical imbalance. And I write about this in my book because pharmaceutical companies, I think it's fair to say, they don't necessarily have our best interests in their hearts, and they want to generate as much revenue as possible. So if you frame it as, it's an oversimplification. So if you frame it as a chemical imbalance and say, here's this wonder drug, Prozac, it will help to restore the balance. Look no further. And that can be deceptive because we look at the evidence and it's not due to chemical imbalance. I would say there are chemical changes for sure, but we still don't really know how antidepressants work, their mechanism of action. But that doesn't mean that we shouldn't take them. I mean, there are many drugs for physical health conditions, as you know, we don't know their mechanism of action, but they are still effective. And we know that the gold standard for deciding if certain medications should be approved is the results of randomized controlled trials, right? So I think we have to be careful. We have to be cautious. We shouldn't just frame major depressive disorder as a chemical imbalance. I think there are chemical changes. And we know, for example, with the SSRIs and with the SNRIs, the selective serotonin reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors, for example, they have an influence on the different neurotransmitter pathways in the brain. We know that, right? But I know I'm repeating myself, but repetition is emphasis. Like, we still don't know the mechanisms of action, but that doesn't necessarily mean that we shouldn't consider taking medications as part of a holistic approach. But I want to take this opportunity to say, I think our threshold for prescribing psychiatric drugs, I think is too low. And I think there's a lot we can do before we get our prescription pads out.
Yeah, I think you hit the nail on the head there with the prescribing, because we'll talk more about what we can do before we get to that stage. Because often what happens in a primary care setting is we're often the first people to see patients with depression, but normally we do try something like CBT. But the problem with the CBT, it's so bad. I feel
it's low
like
quality, isn't it?
Yeah, I don't think I've ever seen it be effective, in the public sector. And then inevitably what will happen is the patient will come back and get started on an antidepressant.
Yeah.
And because they can't get into a doctor, they'll stay on that, and they just, for many years, they're on an antidepressant, slowly increasing the dose without any real effectiveness. So what, in your experience, is the best kind of first-line treatment for someone with depression? I know it's hard to say because obviously everyone's different.
I can talk about what was helpful for me.
That'd be good, yeah.
And to be clear, we have to have an individualized approach to mental health. So what is helpful for me may not necessarily be helpful for others, but it might be. So I'll just share it. The tools that I have utilized. Lifestyle interventions. The importance of modifying your lifestyle for not just your mental health, but your physical health, that can't be overstated. It's difficult because it's a vicious cycle. I'll explain. So you have major depressive disorder, and you can have reduced motivation. You have reduced energy. You don't even have the energy to get out of bed, right? Let alone go for a 5-kilometer run to start off with. And so I'm sure, are familiar with behavioral activation, right?
Yeah.
And when you try to activate that behavior, the behavior of going for a walk, for example, you start off by going for a walk or just even getting out of bed. And then you gradually increase the distance that you cover, or you walk or you run. And that's what I did. So it's difficult, I can't deny it, but the health benefits are enormous. So to answer your question, lifestyle modifications, lifestyle changes, increasing the amount of physical activity that you do, and that could be different types of physical activity. It could just be going for a walk, cycling, gardening, swimming, participating in team sports. But that's definitely one of the tools that I personally utilize. And then we talk about diet as well. We know that there's a relationship between gut health and brain health. So when I improved my diet, I also noticed that my mental health improved as well. And those, I would say, are some of the initial changes, the lifestyle changes. And the thing is, it takes time. It doesn't happen overnight. I know that a lot of us, we want a quick fix, right? Snap your fingers. But unfortunately, there is no magic bullet. And it takes time. Recovery is a process. And it took me many years, actually, I made a full recovery. But it took me a few months to recover so that I could start functioning again, because there was a period in my life, rock bottom, and I just was unable to function.
It's interesting. And how effective or how powerful, and it's hard to quantify, but how powerful is exercise, in helping someone who's feeling low or depressed in comparison to a medication?
Sure. You can quantify it. They use certain outcome measures, certain tools, and I have a very close friend of mine, Professor Brendan Stubbs, who arguably is the world authority on exercise and mental health. And multiple randomized controlled trials revealed that exercise is as effective, if not more, as psychiatric drugs, antidepressants, for example, in the treatment of major depressive disorder. So yeah, plenty of evidence out there to support the efficacy, if you like, of exercise in the treatment of mental health conditions, not just major depressive disorder, other types of mental disorders such as post-traumatic stress disorder and generalized anxiety disorder.
Why is that? I mean, a lot of the things that people say around exercise around to do with dopamine. I don't know if obviously I'm sure there is an aspect of that, but is it more than that? Is it more like, is it, you know, is there something deeper than just a chemical temporary? Because obviously dopamine being released is temporary, right?
Yeah.
But and also some people get addicted to exercise even, so they go too far. Is that, again, I don't want to use the word chemical imbalance, but is anti-chemicals again, or is it more than that?
I mean, there are physiological changes, right? There are biological changes. It can stimulate the release of endogenous endorphins, those feel-good hormones. Sure, that can be temporary, transient, but there are longer-term changes. And I'll be honest, it's not my area of expertise. And there are also, psychological rewards. And I discussed this with you earlier. Like when you set yourself a goal, and when you achieve that goal, the psychological rewards are immense, and that can reinforce the behaviors. So I think those are some of the mechanisms that might help to explain why exercise is so beneficial for our mental health.
And is it, so you say exercise, I know there's people like looking at detail, is it cardiovascular weight training or a bit of both, or whatever you like personally like? Because I know they behave a bit differently, but almost.
Oh yeah, I mean it does definitely, doesn't it? And there many different studies. Is it, for example, high intensity interval training, for example? Is it long distance running, or is it resistance training or weightlifting? And I think all of the above. But it does depend on the individual, and it also depends on the stage of the individual's life. Like for me personally, I know it's anecdotal, but when I was younger, I found lifting weights was more beneficial for my mental health. But now it's like, and there was a period when I was just doing calisthenics. Like I would just bang out 500 push-ups a day or 1,000 push-ups a day. Whereas now I go for a 15 to 20 kilometer run, at least 6 to 7 days a week. And that's what works for me.
So obviously that leads quite nicely on to potentially the next form. So say someone's doing everything with lifestyle. I think what you can use as well, alongside that is, we talk about CBT, but I think people sometimes get confused with, you said earlier, even just with what is a counsellor and what is a psychologist and the different types of CBT, because I think that's very important, because I think we offer maybe just one type and people give up too soon. But if it is a very powerful tool if you know which types there are out there.
There are different modalities. And for example, it could be a CBT practitioner who provides it, or a licensed therapist, and you have low intensity psychological interventions, cognitive behavioral therapy. You can have behavioral activation, depending on the mental health condition. For example, we know for obsessive compulsive disorder, you have something called exposure and response prevention. My personal favorite is psychodynamic psychotherapy, and that is longer term. So usually with CBT, for example, you might have 12 sessions, a session per week, and you'll be done in 3 to 4 months. Whereas with psychodynamic psychotherapy, we're delving into the unconscious. And so that's usually like over a year. It can be longer, depending on the depth of the wound. But to reiterate, we delve into the unconscious because the mind mounts these defense mechanisms, examples of which are repression and suppression and denial. And I think the aim is to have that breakthrough, right? To have that insight and to try to process that unresolved trauma. Because I would argue that we're more traumatized than we realize we are, because the unconscious mind, by definition, we're not aware of what's being buried, what's being suppressed, what is being repressed. And so through therapy, we can process that unresolved trauma, which can be a huge relief, because it's like we're carrying this burden, like we're carrying this weight, which is preventing us from realizing our potential. And it's influencing our mental health and our interpersonal relationships and our functioning. It might be that you can have like a disproportionate reaction, right? Why is it that I'm so cranky, or why is it that I'm so irritable? You know, it's like this the smallest trigger, and it might be because of the unresolved trauma which you haven't processed, which is influencing your emotional reactions. For example, your sensitivity to criticism or rejection, or your fear of abandonment. You know, all of these things.
So you mentioned unresolved trauma. I mean, a lot of people in listening or watching may think that could be something quite massive, like, you know, being attacked or something like that. But
Yeah.
but the trauma is subjective, right? So the person,
God,
I mean,
yeah,
so it
so
could,
important.
for example, say if you, I don't know, maybe might have failed an exam or something that might from the outset seem relatively minor, but that you're saying that could potentially be a cause as well. Because I think pinning down the traumatic event is very difficult to do. And I think a lot of the time people might ask these big red flag things, you know, like have you been, you know, is anything major happen, any bereavement or anything like that? But
Yeah.
I think it's important to know it can be other things, right? It can be anything.
Well, you said something very important. Trauma is subjective, and we should never invalidate a person's trauma. And one of my favorite quotes ever that I share often is saying to someone they shouldn't be depressed because other people have it worse. It's like saying to someone you shouldn't be happy because other people have it better. So never, ever invalidate someone's trauma, which is deeply subjective, because without validation, there can be little to no healing. So we don't know. I think we make assumptions, don't we? We might listen to someone share their story, and we might think, oh, that doesn't sound so bad. But that's quite dismissive, isn't it? And invalidating, and that can be harmful. So take the time to listen and be mindful that one of the biggest problems in communication, this is another one of my favorite quotes, is that many of us listen with the intention to respond and not with the intention to understand. So yeah, try to be an empathic listener and listen with the intention to understand and not with the intention to respond.
I think a lot of people love to be, I say resilient, but in terms of, you know, there are people who are very resilient out there, but a lot of the time they may have gone through a lot of trauma to get to that stage. Now, say people are listening out there, what do you think are so what have you seen? Are there certain traits or things people do to come out of depression and make sure they don't go back into it again, as opposed to someone who's in depression, you know, for many, many years? Is there something that they do different that you've seen? Because I think that's important, because I think a lot of people go down the route of treatment for depression, but the outcomes are so varied.
Yeah.
But what have you seen from your experience that some people do that are like, it seems to work all the time to help with depression?
I think we have made progress when it comes to combating, challenging mental health related stigma. So you can have like the public stigma, and then we can internalize that public stigma and develop something called self-stigma, right? And we can be in denial. And I think it's difficult to be brutally honest with yourself and to accept that you have mental health problems because of the shame, because of the stigma. And I think one of the most important things is to be brutally honest with yourself and to engage in introspection and to be insightful and to be receptive as well, and not to be defensive, because as I said, the mind mounts these defense mechanisms and we might be in denial. So it might be that you know someone who you can confide in, a romantic partner, a loved one, a family member, and you reach out to them. We call this surrogate measures because you might not realize that, you might not have that insight that you are actually struggling with your mental health. And you might not notice what the early warning signs are, but a romantic partner, a loved one, a family member, they can be more objective, can't they? But I'm aware that loneliness is a huge issue, and we don't have these social connections, right? And that is incredibly important. Another tool that I utilize, social connectivity. I'm extremely blessed because I have my best friend. I can just pick up the phone and I can confide in him. And if only there were more people like Wasim, he's my best friend in the world, I think there would be less people attending the emergency department in the mental health crisis if everyone had a Wasim. If he could just pick up the phone and confide in a friend who you know will not judge you and is that safe space for you, is that sanctuary. Because he can be more objective. And although he's not even a mental health care professional, by the way. So yeah, I hope that answers your question.
No, it absolutely does. And this might be a hard question to answer, but why do we get medications in particular so wrong for mental health? I mean, I don't know whether it's right to admit this, but I've seen very few patients who, rightly or wrongly, are on antidepressants who have, said that it's completely gone away. Do you think that's the way we practice medicine here in the UK? Maybe you're in Canada predominantly, so
yeah.
It just never seems to get either the type right or the dose right, or are we sticking to guidelines too much rather than looking at the patient, which I think happens a lot. But I just find it that we never seem to get it right from in patients, predominantly, and that's certainly in the primary care setting. And obviously, by the time they come to you, you may have to try and fix all that.
Well, I mean, you only get 10 minutes, right? And a thorough psychiatric assessment, which includes a mental state examination and a risk assessment and asking the patient about their childhood experiences. And unfortunately, we know that many persons are the victim of adverse childhood experiences. All of that takes time. And then you can diagnose them, right? I think a lot of people are misdiagnosed, especially with bipolar affective disorder, right? You might think, they've got unipolar depression. They don't have bipolar depression. And then you start them on an SSRI, and then they end up developing a hypomanic or a manic episode, right? That was induced by the SSRI, which we know is contraindicated in persons who have bipolar depression. That's just one example. But I mean, it helps having the knowledge and having the expertise, but also having the time as well. But most mental health problems are managed in the community by family doctors. So it's, I think that might explain why a person's mental health condition may be mismanaged or not managed in the right way or in the best way.
I think one of the biggest things that you said there was around the correct diagnosis. In particular, I see very often, actually very often more than, more than I thought I would, is when patients get labeled with depression when in fact they've got something like PTSD.
Yeah.
And because obviously they link very closely, but
there's a lot of overlap, yeah.
Yeah, so obviously the treatment for depression is not going to help someone with PTSD. So they're on this, rabbit hole of being diagnosed with depression. No one ever questions that. And then they go down medication, therapy, and all this stuff. And then
that's the thing, and it usually sticks. The label sticks, the psychiatric diagnosis. You can't shake it off, can you? And I see this a lot in persons with autism, especially autistic girls and women. They tend to be misdiagnosed with EUPD, emotionally unstable personality disorder. That's not uncommon. And so they don't receive the correct treatment for the autism. And also, unfortunately, EUPD or borderline personality disorder is one of the most stigmatized psychiatric conditions, isn't it? And that just makes things worse as well, the stigma.
Yeah, there's a lot of things. So there's a lot of things you said there. I mean, so let's unpack it. So firstly, just starting with the misdiagnosis. So say if someone's being diagnosed with depression and nothing's working, is it right for them to maybe assume, okay, look, is there something else going on? Because I know a lot. Because sometimes patients are scared to ask, could it be something else? That question. And that's not a bad question. If I hear that from a patient, I think, hang on a minute, my brain kind of switches gear, because sometimes they come in as a depression patient, my brain's in depression treatment mode. But if they come and say, look, I think it could be something else. Yeah. And I think that's a good question to ask from the patient. But what kind of things would they be looking out for? Say someone's got depression and nothing is working for them. What can they do to almost get the help they need if they suspect they don't have just depression? I say just depression. I don't mean just depression. I mean as opposed to another condition.
Unfortunately, there's a treatment gap, isn't there? And what I mean by that is the demand for specialist mental health care far exceeds the means. In other words, we don't have enough psychiatrists. I mean, how long is the waiting list for an autism assessment, for example? 2 years? 4 years?
Minimum 2 years. Yeah. Probably longer, yeah.
So we call that the treatment gap. And to quote my friend in Harvard Medical School, Professor Vikram Patel, who is the world authority in global mental health, when it comes to mental health, all nations are developing nations. Because of that huge treatment gap, a person with autism having to wait to for even longer, 6 years for a specialist autism assessment. So I think all of this is contributing to the problem. They need to have an expert assessment, and that needs to be done by the consultant psychiatrist. And I think what you and your colleagues are doing in primary care is outstanding. It's incredible. And especially the content, and I've commented on this, the content that you create is very high quality content about mental health. Mm-hmm. So I'm not in any way, shape or form attacking or criticizing general practitioners or family doctors. I think it's down to resource allocation, so that we can train more doctors to become psychiatrists. Because I think now it's like the ratio now is 10 applicants to, I think it's 5 to 1. For every one specialist post available in psychiatry, there are like 5 applicants. It used to be undersubscribed, now it's oversubscribed. Yeah. So yeah, we need more training posts, but that doesn't fix the problem now, does it?
No, yeah, because I trained in surgery, I think I mentioned, and then I was at a kind of crossroads, psychiatry or general practice, and I went for general practice. But okay, so there is a big waiting list in particular for autism, but you're here. So I think we should take advantage. Because autism is a massive question. A lot of people are coming in.
A lot of people are self-diagnosing.
And also almost a lot of people are paying to go private, right? And there's an argument to say if you're paying for a private assessment, the chances are you're going to get an autism diagnosis. I'm not saying that's every clinic, but there is risk of that as well. What are the kind of, I know it's hard to say again, but what are the most common signs that someone might have that may point them towards a diagnosis of autism, or you towards a diagnosis of autism?
I mean, it's a neurodevelopmental disorder, isn't it? I mean, the impaired reciprocal social interaction in our psychiatric textbooks. So usually kind of like social withdrawal, things like having a rigid routine, sensory overload, being prone to having meltdowns, for example. There might be some delays in reaching certain developmental milestones, walking, talking. That's why it's important to do a thorough assessment of their neurodevelopment. But, and there's a lot of overlap with emotionally stable personality disorder. So there might be, for example, sensitivity to criticism or rejection, but also a lot of kind of self-stimulating behavior as well. So that's something called stimming. So those are some of the screening questions that I would ask, but they would need to be seen if there is a suspicion that they have autism. They would need to be seen by an autism specialist, a neurodevelopmental disorder specialist. And unfortunately, as I said, the waiting time is too long.
I think that's true, but I think there's no question the rates of autism and ADHD is another one is going up. Now, why do you, again, we asked the question, but ADHD in particular is another one where a lot of children and adults are coming in asking for an ADHD assessment or diagnosis, because I think obviously with the rise of social media, there's been lots of documentaries about it.
That's a factor for sure. Yeah, absolutely. I think social media plays an important role. I think we're getting the public are not as unsuspecting as they were with the dawn of digital age and all the influencers, and but there are other factors as well. We know that, for example, obesity can be a risk factor. So if your mother is obese, for example, that can double your risk of developing autism yourself. And if your father is obese, then that can quadruple your risk of developing. So, this modern world we're living in, the environment, of course, there's a genetic component for sure. But there are things that happen even in utero when you're in your mother's uterus, for example. And I'm sure the epigeneticists will have a lot to say about that as well. So multiple factors, environmental, genetic, social media, improved awareness. And I think a lot of people also identifying as neurodivergent as opposed to neurotypical, which goes back to self-diagnosis. And we have to be clear about this. You need to see a specialist to have a formal psychiatric diagnosis of autism. You can't diagnose yourself, which is happening a lot.
Yeah, I think it goes back to the point that no one can get in to see a psychiatrist at least for a couple of years here. But
Yeah.
you mentioned social media and in particular, phones. So
Addiction.
how bad are they? I mean, I know the easy answer is very bad, but if that's the case, why are they so potentially bad and just damaging not only children but adults' mental health?
Yeah, I mean, it's so addictive, isn't it? I would say I'm addicted to it as well. My device and social media, and we mentioned before, I guess, the dopamine hit, and it becomes a habit. And I think the Secretary General in the US, he recently published a report about how harmful social media can be for the Surgeon General, not the Secretary General. Sorry, the Surgeon General in the US. I forgot his name, but he's been very vocal about this. So it can be beneficial. You can connect with like-minded and like-hearted people all over the world. But it becomes problematic when, for example, you take your smart home to bed with you, right? And then that will have a negative effect on your sleep. And we know that your sleep hygiene is incredibly important for your mental health and your physical health. So that's just one example.
Yeah, it's hard because I think it's hard sometimes when patients come in, and you say social media is bad on the phone, because it's a thing we're going to have to live with, right? It's something that it's unlikely it's going to completely go out of our lives. So I think
ultimately, I think it's a force for good.
Yeah.
But we just have to moderate it.
Yeah, I'm like you. I find it very hard sometimes to switch off of my phone. I admit I go, I'm in bed sometimes just on my phone looking.
Doom scrolling.
Yeah, which is is not ideal. I mean, I think I read it's almost again going down to the reward system where you're on your phone, you get instant reward from looking at notifications, and if you don't have that, you kind of crave it, and that it's almost it's addictive. I think it's what part of the brain is it acts on that. It basically it's like if you don't have that, you almost start having withdrawal symptoms.
Yeah, absolutely. Yeah, definitely, and it can feel like physiological withdrawal symptoms, like the same type of withdrawal symptoms that you would get if you were dependent on alcohol or recreational drugs, right? Because in a way, it can be seen or viewed as a drug for sure. So it's like trying to stay in control or kind of limit the amount of social media that you use, being sensible about it.
Yeah. Again, that is a very
which is easier said than done.
Yeah, I was going to say the exact same thing.
Yeah, of course it is.
One thing I think I want to go on to is narcissism, and that again is one of those terms that's thrown around for everyone.
Yeah, you have to be careful. Yeah,
but it is actually an actual disorder, right? And I think
narcissistic personality disorder is a disorder. Yeah, for sure. Yeah,
and I think we have to be careful because I think. Because everyone says it, potentially about an ex-partner they're not happy with or they don't get on with, but
yeah,
it is a condition just like anything else. But if you could help clear up kind of what actually would, facilitate a diagnosis of a, narcissistic personality disorder over, just something else that's not a mental health disorder.
Well, a person can have narcissistic traits and not necessarily have the full-blown narcissistic personality disorder. So it would have to be a licensed professional, usually a clinical psychologist or a psychiatrist who is an expert at assessing a person's personality structure. And we know there are diagnostic criteria. If you are in the UK, then we use the ICD, the International Classification of Disorders, or if you're in the United States, you use the DSM, the Diagnostic and Statistical Manual. So there are diagnostic criteria that must be satisfied for a person to receive a formal psychiatric diagnosis of, for example, narcissistic personality disorder. Again, I know I'm repeating myself. So you can have the traits. A person can have this grandiose sense of entitlement. It depends, I guess, for example, if they are a covert narcissist, then they have this tendency to victimize themselves. And, you've heard about the gaslighting before and, a person being very callous towards you. And these are all narcissistic traits, but I agree with you. We have to be careful not to just label everyone as having a narcissistic personality disorder because, you'd have to be a specialist to make that diagnosis.
Yeah, it's interesting. I see quite a lot, in particular social media, a lot of videos about narcissism, what how to deal with a narcissist. And because I think also, because if it is true, even narcissistic traits can lead to sometimes abuse for a partner. And I think, is there a risk of someone with narcissistic traits developing full-blown personality disorder? Is that one of the risks, or are they?
It is a risk. Absolutely, yes, it is a risk factor if you have narcissistic traits, for sure. Yes.
And does that lead on to something like psychosis? Now, this is interesting because I was watching the news the other day, and there was you might have seen it, where there was a body cam footage of a police who just walked into someone's house because the GP raised alarm because they hadn't seen this elderly couple for 4 years. So they walked in, and then the daughter was there. She kind of calmly said that she essentially murdered both her mother and father.
Oh, I saw that. Yeah.
And she was saying it kind of just so calmly, and so that that made me think. Okay, that this person clearly has some form of or psychopath.
We have to be careful. Yeah.
You have to be careful.
We have to be careful, but there might be certainly psychopathic traits, but there is something called the Goldwater Rule in the US, and the Royal College of Psychiatrists in the UK supports it, and that's not refraining from making any psychiatric diagnoses from afar. In other words, we may have seen a video or a clip that went viral on social media, and this person was very callous. They spoke very nonchalantly about where the police officers can locate the corpses of her parents who she murdered, and that's very callous, and that is a trait of psychopathy for sure. But that doesn't necessarily mean that they are a psychopath. They would need to have a specialist assessment.
I think one thing in particular that I did a short form video on this was kind of intrusive thoughts and almost like internal monologue. So I have this voice all the time in my head just speaking thoughts.
Yeah, or the inner critic sometimes.
Yeah, and thankfully for me, it's nothing sinister. It's just kind of just. So, and I think I read a stat somewhere, something like 20% of people don't have that in a monologue. So, in particular with intrusive thoughts, they can be normal, but when would you think they can become kind of something to worry about? Because these thoughts can be anything. They can be, sometimes they can be thoughts of you potentially harming someone or harming yourself. But obviously, most people don't act on them. But what would be kind of the boundaries someone starts to think, hang on a minute, this is getting a bit more than just a thought, and I should seek out help rather than leaving it too late before it actually turns into something?
So when you say intrusive thoughts, I think of a few things. I mean, I think, for example, about obsessive compulsive disorder, and the obsessions can be very intrusive. But the person living with OCD knows that it's nonsensical, and that they have insight into that. And I think it goes back to the 3Ds, doesn't it? So is it causing you considerable distress? Is it causing you dysfunction? And is it causing you or others any danger? So, for example, you may have heard of command auditory hallucinations. Which is a psychotic symptom, right? That's more than an intrusive thought. That is to the person suffering with psychosis, for example, they actually genuinely believe that the voice is real and it's external. So it's not actually. So when I'm with a patient, one of the questions I'll ask, if they say that they can hear voices, I'm like, can you hear the voice through your ears like you can hear my voice? Because it's external. Like you might be in the room, you hear a voice and you turn around because you want to look for the source. So it's not inside your head. So that's one way to try to differentiate between like the internal monologue that you were saying, or the inner critic that many people have in anxiety disorders, and the auditory hallucinations that a person with psychosis experiences. And so, that takes expertise as well. And so that's why you would need to see a psychiatrist to be able to kind of distinguish between intrusive thoughts or auditory hallucinations. Going back to intrusive thoughts. So I gave you the example of obsessive compulsive disorder. You get the obsessions. It's intrusive. It's recurrent. It's distressing. It's frequent. So these are some of the questions that I'm asking. How frequent are these intrusive thoughts? Are they distressing? Do they stop you from concentrating? Do they prevent you from focusing? Are you unable to function in the workplace or at university or at school or at college because of these intrusive thoughts, because of the frequency, because of the intensity? Is it increasing in intensity? Was there a trigger, an identifiable trigger? What are these thoughts? What are you talking about? Are they traumatic flashbacks of when you were abused as a child, for example? Was it physical abuse? Was it emotional abuse? Was it sexual abuse? Were you in a life-threatening situation? So these are like all the questions that I would ask. So, but to answer your question, yeah, just go back to the 3Ds: causing you considerable distress, causing you any dysfunction, and causing you or any others danger.
And why do some people? And do you think, in particular, like schizophrenia or psychosis and all these kind of diagnoses, is there something in common that people may have had when they're younger that cause people to? Because I find it very interesting, why some people, become psychotic or have psychotic episodes, or in turn go on to develop something like schizophrenia, which obviously has varying levels of how bad it can be. But what have you seen? Is there common traits in people? Either they've grown up with something, or they've had a particular trauma, or
trauma plays a big role. We know that adverse childhood experiences increases your risk of developing psychosis and schizophrenia. But we know that probably the biggest risk factor is a family history. There's a strong genetic component, especially in monozygotic twins. So if you have an identical twin and he has schizophrenia and you have the same genetic composition, 50% of persons who have an identical twin who has schizophrenia also have schizophrenia. So there's a big genetic component there. But I mean, I mentioned to you the trauma, the adverse childhood experiences, but also illicit substances. Cannabis, that's another major risk factor that can increase your vulnerability to developing psychosis. Also immigration. So we know that if you're a second generation immigrant, that increases your risk of developing psychosis. I mean, we know that even first generation immigrants, so let's say, for example, your parents, my parents, whatever, they migrated from Lebanon to Ireland. So that's a risk factor. But being born in Ireland would make me a second generation immigrant. And that's an even bigger risk factor to developing psychoses than compared to a first generation immigrant.
That's interesting. And also these patients just historically have less access to healthcare.
Yes, absolutely.
It's a double-edged sword there, where they've a high risk, and then on the other flip side, when they potentially get these conditions, they can't seek out the help that they need.
Yes, and we know that you have the duration of untreated psychoses. So, how long do you live with the psychotic symptoms until you actually receive treatment? And we know that for persons of color, the acronym we use here is BAME, Black, Asian, and Minority Ethnic Backgrounds. That duration of untreated psychoses, as far as I'm aware, is greater than in persons, in white persons. Because of the barriers, stigma, and the inequalities and the inequities.
And culture plays a big part.
Culture as well, absolutely, yeah. It's generational, it's cultural, multiple barriers.
I think one thing that's clear over the last few years is the amount or the risk or the numbers of suicides happening, in particular in young males.
Yeah. 75% of suicides are by men.
Wow, that might, I didn't know, is that high?
Male to female ratio is 3-1, yeah.
And I'm not sure this
more women attempt, but more men die from it, yeah.
Really? Wow. Yeah. And one thing I think is important to discuss is maybe something called is hidden depression, where it's sometimes depression is in people that you wouldn't expect.
Yeah. Or high functioning depression, or I think you mentioned the mask earlier on, right? I mean, that's why I say, like each of us are fighting battles other people have absolutely no idea about, because it's mask, right? Which can be so misleading, if not deceptive. So in a world where we can be anything, be kind, because that one cruel word can be enough to push someone over the edge.
I think raising awareness, I mean, that's so true. I think, because you never know what someone's going through. And I think what can people look out for signs of hidden depression? I know it's very hard, but I think that's key, because most of the time it's picked up by a loved one, because the person with hidden depression is never or unlikely going to bring it up because, they deem themselves to be almost not depressed. But what can someone, or how can you pick up on hidden depression if you're, say, just a loved one?
I think some of the more common manifestations of hidden depression would be irritability and being argumentative.
Okay.
Those are some of the more common features in my clinical experience. Maybe subtle personality changes. They may have been more softly spoken, more mildly mannered. But I mean, other things as well. You might sleep more excessively. You might have reduced sleep. You might not necessarily feel depressed, although that's one of the symptoms for the diagnostic to receive on the diagnostic criteria. But yeah, I think it's also the kind of the denial, the minimization. These are some of the psychological defense mechanisms, because maybe we've internalized that stigma. There's the shame. It happens to other people. It happens to weak people. I'm not weak. So I think those are some of the psychological explanations. But how it manifests, to answer your question, yeah, I would say usually irritability, sometimes even self-neglect. So they might appear more unkempt or disheveled, or they let themselves go. So there may be some weight changes. Not so much difficulty in concentrating. I wouldn't say that presents, because they are still high functioning, but certainly not. Their cognitive capacity is not as good as it was prior to becoming depressed.
And is the management for hidden depression the same as it is for depression alone, or is it once they've got a diagnosis?
Yes.
So it can be the same sort of
treatment. The treatment's the same. Yes.
Yeah.
Absolutely. Yes. Yeah.
Okay.
Definitely.
So this is the diagnosis that's tricky, because I think. And just to be clear, it can, you said high functioning, so by that it can be a CEO of a company, it can be,
it can be anyone.
It can be anyone.
Absolutely. It can be anybody. Yeah. And I think we have to be careful, because we might say to ourselves, I have nothing to be depressed about. But we are all vulnerable. I mean, don't get me wrong, of course, we know that poverty is a major risk factor to developing major depressive disorder. But depression is cruel like that. It can affect you irrespective of how financially comfortable you are.
I think that's important to know. And I think hidden depression is one. I think about a lot, actually, just because, just from a doctor in primary care, I think it's so hard to pick up on, and catching those people early who may well go on to do something more serious is so key. And that's why I just want to, what are things people looking out for? And that was a very clear explanation. And I'll be looking out for that as well in patients, because sometimes it's simple things like you've not seen a patient for a couple of years, or they're not following up a treatment plan, or, this is something I think that we should all have always in the back of our mind, to make that diagnosis.
Also, I would say another big one, I should have mentioned this, social withdrawal. I would say that's another big one as well. So they might be functioning in the workplace, for example. They might be meeting targets, but they are declining invitations for social gatherings, And don't get me wrong, not everyone who is introvert is depressed. I get that, but these are persons who usually they would accept these invitations, but now they are, in a sense, isolating themselves.
Yeah, I think that's an important one. But then again, to know it can be something else. But I think it's important to always have that. If someone, because if someone's coming in, they a high flying business person, and they suddenly they're doing well at work, but so you may think everything's normal. But if there are these things lurking underneath, they're the ones at high risk. So they're the ones I think we need to catch.
They are absolutely, and it's tragically it's not uncommon. Like when there is a suicide, and it's, as I said, it's not uncommon. Oh my God, I thought they were, on the surface, they were so happy, they were smiling. Look at their pictures on Facebook, for example. I thought they were living the perfect life, and it can be deceptive like that, for sure. The mask.
Yeah, absolutely. Now, a big thing, dementia, memory problems, memory loss.
Oh yeah.
It's a huge topic. But I think dementia is becoming, again, like all mental health problems, become more and more common. Yes, people are living longer, but there's also a lot of more early onset dementia, which can be down to pathology as well, right? Which is genetic. But when should people start worrying about their memory? Because a lot of time people come in saying, I'm forgetting the odd word here and there. When is that something to be worried about? to the point where a patient should say, okay, look, I need to get seen here and maybe have some interventions, like some brain training or memory training?
Yeah. I mean, I've worked in the memory treatment clinic, and it becomes concerning going back to the 3Ds, the D standing for danger, when, for example, they forget to lock the door at night, or they forget to take the stove off, and there might be a small fire, but that could potentially have been a large fire. You know, things like that are to emphasize, D for danger, or when they go wandering and they get lost, and that could, potentially compromise their safety, their well-being, and their life as well. So for me, it's the D, definitely.
And is there anything people can do to safeguard their memory? Because I think about this a lot. Because physically, I care about my health physically, but I think the one thing that I think I'm more scared about losing is my brain, my cognition. Because I think not just from a personality point of view, but it just in my opinion, is the most important thing to look after. Now, yes, there's exercise, having good diet, which is obviously key, and I'm saying that it's a second thought, but that really should be the cornerstone of looking after your.
Of course, yeah.
But is there anything else you can suggest to really, really help? Because there's lots of things out there, lots of snake oil, I suspect. But what things are out there that you know are proven or highly likely to help without causing harm for memory?
Well, I mean, when you talk about modifying your lifestyle, I'm thinking about vascular dementia, right? And we know the risk factors for vascular dementia: smoking, hypercholesterolemia, hypertension, high blood pressure. So if you modify your lifestyle, then you reduce the risk of developing these conditions, and that can reduce the risk of developing a type of dementia known as vascular dementia. So those are some of the things that we can do. Yeah. I mean, you may have come across these articles before about engaging in intellectually stimulating activities, crosswords, for example. Even, for example, if you're younger, learning a new language and speaking that language regularly. So we know that multilingual persons are at reduced risk of developing dementia. But I think the best thing that you can, because there's no cure for dementia, is there? But we know that you can try to control it, and you can try to halt its progression, if you like. And yeah, so I mean, early assessment, early intervention is crucial. So that doesn't necessarily prevent you from having it. We spoke about some of the preventive measures that you can employ, but certainly trying to halt disease progression, early assessment, early intervention.
I think we spoke slightly off camera about supplementation, and you were saying you're not obviously adverse to it.
But not at all, yeah.
Yeah, and there's been a lot of time. The two that I really stand out for me are, I that have been going around a lot, and I think have some evidence. But I want your thoughts on it.
Yeah.
One is creatine. Now, obviously, creatine was initially, it is still mainly used for help with the gym and muscle mass. But there are some sort of newer studies showing that it can also help with cognition and Alzheimer's disease.
Yeah.
But I wonder if you had any thoughts on creatine.
Well, I mean, first of all, I'm not a consultant in later life psychiatry from 65 years and above, and it's usually older persons who receive a psychiatric diagnosis of dementia. So it's not my area of expertise, but as far as I'm aware, I wouldn't say there's a robust evidence base for creatine and the role that it plays in reducing the risk of developing dementia.
And what about things like omega-3s and 6s that people have been around for a long time, that people are always kind of saying, take this, and again, the evidence, there is some evidence out there, but it's not robust. But again, have you got any thoughts on that? Have you ever had patients who have had good kind of experience?
I mean, so long as there are no unacceptable, intolerable adverse effects, and that it's not harmful and that it's safe for you, but also I don't want to get people's hopes up too high. So as I said about other supplements, such as creatine, I don't think there's a robust evidence base, but that doesn't necessarily mean that I'm averse to advising patients to take supplements to reduce their risk. But I just don't want to get their hopes up too high.
No, I don't know whether this is relevant, but I take magnesium glycinate because I just find that it helps. So I know if it does pretty help me, just relaxes me and helps me sleep. So and
there might be a placebo effect, right?
Yeah, potentially, yeah. But I think it is a good one for me. One thing I have to mention is benzodiazepines.
Benzos.
Yeah, I think it's yeah. Yeah, I don't know. So I think the reason I have to mention because
Where do we
I think,
begin?
yeah, because I think, you know, so I mean, like lorazepam, diazepam for patients, I think what is a benzo? Because most people have heard of a diazepam, lorazepam. Now, these are very old medications, and they are very, very effective at treating anxiety in particular. But
Panic attacks, yeah.
yeah, but the problem comes in their dependency and their addiction and their risk of abuse, in particular if it's mixed with alcohol and things like that, which can be very dangerous. Now, I just want your thoughts on benzos, you know, from a psychiatrist, because I've got my own thoughts, but I want to know what you think of them.
I think we have to be incredibly careful and cautious because, on the one hand, I empathize. The symptoms of a panic attack, of generalized anxiety disorder, and benzodiazepines like lorazepam are usually prescribed to treat those symptoms. They can be debilitating. But as I said earlier, I think there's a lot we can do before we get our prescription pads out. But also, we should have non-pharmacological approaches and pharmacological approaches. It shouldn't be one or the other. I just have a high threshold for prescribing a benzodiazepine like lorazepam because of the risk of dependence and tolerance. And to quickly define those terms, dependence is when you can develop withdrawal symptoms upon the sudden discontinuation of taking the substance, and tolerance is when you need more of the substance to achieve the desired effects. And it's very well known that you can become addicted, dependent, and tolerant on benzos. So use it sparingly. It's not part of a longer term strategy in the treatment of generalized anxiety disorder and panic attacks, for example. I'm not strictly opposed to it. I just think that there's a lot we can do before we prescribe those powerful psychiatric drugs, which can have severe adverse effects.
Yeah, I think.
What are your views?
I've said it quite a lot. I'm not a fan of them. I don't.
Oh yeah, I'm not a fan. I'm absolutely not a fan.
Yeah,
absolutely not. No.
I think even to the point where, because a lot of the time patients will come in, you know, the risk is they do often get. I mean, if I see a patient who's requesting benzodiazepine, I'll never give it without a review, and I obviously if someone's dependent on it or addicted to them or has a high tolerance to them, it can sometimes hard to withdraw them because obviously there's a risk of withdrawal.
And they get the
really bad, some of the most dangerous actually, I think.
Terrible withdrawal symptoms. Yeah, which could potentially be life-threatening, by the way.
Yeah, and I think before we give a patient benzodiazepines, we have to be clear on that. And I don't think that's always passed on because all they can help with the anxiety and the panic attacks in particular, I think that, you know, the risk of that, I think being told clearly the risk is very important. And I think in primary care, that's not always the case, you know.
It's crucial. It's crucial. The psychoeducation as well, and there has to be a deep prescribing plan. You can't, because some people stay on the benzos for months, if not years.
Which is bad. And what are the long-term effects of benzo? I mean, when I say long, I always say I avoid beginning them long-term. I'm talking like, you know, a week here and there is absolutely fine, in my opinion. But when you start getting into, you know, months and years, that's when I think is potentially harmful. Because, you know, yeah, but what can be the side effects or the known side effects of very long-term use of benzos?
I mean, we know that it exerts its effects on the central nervous system. So you can get certain neurological symptoms, you can get neurological deficits. But for me, it's like with the tolerance, you want more and more of the substance to achieve the desired effects. And you know this better than I do, that it can be respiratory depression, and people can die from respiratory arrest.
Yeah, and I think so. On the off chance I do prescribe someone a benzo, most of the consult is just about saying, look, you can get prescribed it, but these are the risks you have to be aware of.
Big time.
Because a lot of time, patients I wasn't aware of that. Okay, let's try something else, which tells me, okay, there are other ways we can try before we even have this conversation in the first place. Which
it's a psychoactive substance as well. You know, it will influence your perception, and you can get perceptual disturbances. And for example, if you're driving a car, and you can place yourself at risk and other people at risk as well. I mean, these are all the possible side effects of benzodiazepines that we must educate the public about.
I think it's important because I do lots of. Actually, I've done quite a few videos on benzo just to say, look, they're not as, because people even buy them online because they can't get them from the GP, which is probably the worst thing to do because it could be mixed with other
All
things.
sorts. Yeah, absolutely. Yeah.
That's a big no-no. Now, you mentioned, so I think delusional disorder, delusions, I think, is another word people use. You're delusional,
Yeah, delusional.
But yeah, even me, I don't feel like I have a massive understanding of delusional disorder or delusions. I think they're important because they're a symptom that it's almost hard to say. It's hard to describe as a patient what a delusion is, because even as professionals, as GPs in particular, it's hard to say, okay, what is a delusion? So what is a delusion?
Yeah, it's a fixed false belief held with absolute certainty and conviction, despite robust evidence to the contrary, that is inconsistent. This is important. That is inconsistent with religious or cultural norms. So I'll give you an example. When I'm teaching medical students, one of my favorite books is by an Afghan author called Khalid Hosseini.
Yeah.
And it's called A Thousand Splendid Suns. And it traces the journey, if you like, of a young girl. Her name is Maryam. This is in Afghanistan. And in the book, through Maryam's eyes, she is describing what she is seeing. Her mother is having a tonic-clonic seizure. Her mother has epilepsy. Right? And Maryam said, oh, here we go again. My mother is being possessed by the jinn, a malevolent spirit. And so instead of attributing the behavioral changes to aberrant electrical activity in the brain that you get when you have epilepsy, her explanatory framework is, oh, she's being possessed by this malevolent evil spirit jinn. Okay, that belief, is it delusional to have that belief? If you go back to the definition of a delusion, if it's inconsistent with cultural norms, is that belief that Maryam has, is it consistent with cultural norms, or is it inconsistent with cultural norms? Do they believe in jinn possession in Afghanistan?
Yeah, they do, yeah.
So it's not a delusion. Okay, so that's important. If it's inconsistent with cultural norms, then it increases the likelihood that it's a delusion. So it goes back to fixed false belief. So these beliefs don't have to necessarily be bizarre, because you can have grandiose beliefs, for example, which is bizarre. I'm a superhero, I can fly. It's dangerous. If you're manic, I have magical powers. I can jump off that building. I'll show you. I can fly. That's dangerous. And unfortunately, we usually have to admit these patients into hospital involuntarily because they are in denial. They lack insight. They don't accept that they have a mental health condition. So that, in a way, is a bizarre belief that I have magical powers. But it might be, for example, that you believe that your spouse is having an affair. Is that bizarre? No. But it can become delusional when there is no evidence, there's not a trace of evidence whatsoever to prove that she is or he is having an affair. And it can become dangerous as well.
And do these delusions form part of a wider diagnosis, or can it be diagnosed by itself?
It depends. It depends. I think you would have to do a comprehensive psychiatric assessment. So if there are other symptoms, we call them first-rank symptoms. For example, just to give you an example, first-rank symptoms of schizophrenia, paranoid delusions, persecutory delusions, delusions of reference, but also perceptual disturbances, auditory hallucinations, for example. And then also when they start to neglect themselves and the social withdrawal as well. These are like the negative symptoms. So we would also ask about these other symptoms before we could. So it could be part of a mental health condition, such as schizophrenia, depending on if they present with any other symptoms. But they're usually quite high functioning, by the way. If you have a delusional disorder, you're usually high functioning, whereas with schizophrenia, there is an impairment in functioning. They usually get kicked out of school or fired, and they can be disheveled and they neglect themselves. Whereas with delusional disorder, they can present as impeccable and they can still be very high functioning.
So it's quite hard to make a diagnosis. If they're quite high functioning, and they say, this is my story, it's hard to, it's almost like a disprover to say it's a delusion, right? And so...
But it might be reality, though. It might be that his wife or her husband is having an affair, but then it becomes extreme. it can become extreme to the extent that it can potentially be life-threatening when they are convinced that their spouse is having an affair and they want to kill the spouse. That they can be homicidal. That can happen, yeah.
And is that delusion turning into schizophrenia there, or is that just the delusion already getting so bad?
No, schizophrenia is something else, because there are other symptoms that you would need to experience, and it's not usually that type of. They wouldn't have that type of delusion. It would be a different delusion, a paranoid delusion. For example, I'm under surveillance, and the government, they have hacked my devices. Those are the types of delusion, paranoid and persecutory delusions, that persons with schizophrenia have.
I see. And on the topic of schizophrenia, is it, you mentioned that, so you mentioned earlier, sorry, that patients with schizophrenia sometimes might get kicked out of school, or they're completely non-functioning. Is that always the case? Or if you look at someone, is there a certain point where they just develop these symptoms, or is it like slowly throughout their life?
It's insidious. Yeah. It's kind of like an insidious onset, and it's imperceptible as well. But it's often the case that there is profound impairment in functioning, and up to a third, despite receiving treatment, will still be unable to function, unfortunately.
And so what are so done that diagnosis? I know you mentioned some points there, but what are the diagnostic traits of schizophrenia? I know roughly, but obviously we don't diagnose schizophrenia in primary care. We actually very rarely see it, actually. Yeah. Because patients often, sadly, tend to get sectioned before they see us, especially being undiagnosed, and then go obviously see you guys. But what are the kind of things, that would lean towards a diagnosis of schizophrenia?
I think about some of the cognitive symptoms. Their thoughts can be quite disorganized, and they can even have thought block. And that would manifest as something called alogia, which when there's poverty of speech. And they can, not only can their thoughts be disorganized, but also their lifestyle can be disorganized as well. They struggle with activities of daily living. So there are prominent features of self-neglect straight away, poor dental hygiene, long fingernails. They can neglect themselves to the degree that they can be malodorous. You can smell them from a distance. They can appear distracted. They are responding to non-apparent stimuli. So those are the perceptual disturbances, the auditory hallucinations. So you have what we call the third person auditory hallucinations. So you would ask about the voice, and you would ask them, how does the voice refer to you? Does the voice refer to you in the third person? For example, if you're making a cup of coffee, does a voice provide you with a running commentary? He is making a cup of coffee, the third person. And they can be quite defamatory. Isn't he an idiot? Isn't he stupid? He needs to get to life. So yeah, that's a first rank symptom. And you have the other symptoms as well. For example, the negative symptoms that I mentioned to you, they can have depressed mood. And sometimes it's difficult to distinguish between the negative symptom of schizophrenia and the symptom of major depressive disorder. And there's a lot of overlap between the two. But that's what tends to happen. They tend to get involved with the criminal justice system, unfortunately, because they can be quite vulnerable. And yeah, I usually would see them in custody, for example. They would call me if I'm conducting a mental health act assessment in my capacity as a Section 12 approved doctor. It's not uncommon for me to go to custody and the person to be wandering the streets, and they are at risk of getting hit by a car, for example, because they're so distracted.
I just wanted to say we've covered loads of topics there, and I think we'll have to do part 2 at some point. But I think, where do you want to see kind of mental health go in the future?
Oh gosh,
because I know we kind of, I think we're at the tipping point now where the awareness is there. But it's interesting to hear your thoughts on where you want it to go in terms of treatment, diagnosis, that kind of thing. Do you want it more to be kind of in the community and more patient led, or do you want it kind of like just more awareness spread, or what kind of, where would you say let's say 5 years time, where would you want to see kind of mental health in terms of treatment and diagnosis?
Well, resource allocation, right? If you take the UK as an example, how much do you think of the health budget is allocated for the provision of mental health care services in the UK? What percentage? It's 12%. That's not parity of esteem. It should be 50%, right? A person experiencing a mental health crisis, that's no less of a crisis than a physical health crisis. A person experiencing a mental health emergency, that's no less of an emergency than a physical health emergency. Both demand high quality and compassionate care, and we're not getting that. I think, I want for there to be less stigma. I think we need to get our own house in order, the psychiatric profession. Many people report that their psychiatrists are a source of stigma. Don't get me wrong, there are many inspirational, caring, empathetic, compassionate psychiatrists, but there's still a lot of work to be done. I'd like a framework, a model that is grounded on human rights. And I'm doing a lot of work with the World Health Organization, Dr. Michelle Funk, and she pioneered quality rights, which is an approach to mental health that was grounded in a human rights framework. And to quote Dr. Funk herself, there is no mental health without human rights. I'd like to amplify the voices of persons living with a mental health condition. I think persons living with a mental health condition must contribute to the design, development, and delivery of mental health care services. I'd like to see more humility from psychiatrists and from mental health care professionals and all of these things, really. So, attitudes, resource allocation, respecting and upholding the human rights of persons living with a mental health condition, because often persons living with a mental health condition report that their human rights are violated and that they are, because there's coercion, isn't there? When you section someone, when you detain them under the Mental Health Act, you're taking their freedom away from them. So there's a lot of research now in Maudsley Hospital, for example, in Southeast London in the UK, about kind of advanced directives and empowering and humanizing, because persons living with a mental health condition are being dehumanized. So empowering and humanizing and dignifying persons living with a mental health condition. So I hope that answers your question. I think, I'd like to see more spirituality as well, actually, because I think spirituality can be beneficial for our mental health, depending on the individual.
Yeah, no, I think I wasn't aware it was so low, 12%, because the amount of patients seen with mental health, even in primary care, is at least half.
At least half, right? There you go, and your capacity, right?
Yeah. So it's just one thing. I'll probably let you go to. I've got two more things. So the first one is about, you mentioned about sectioning there. I think there's a lot of misconception by the public, even by doctors, about sectioning, what it is.
Yeah.
What does someone have to do, or what stage they have to be for them to get sectioned?
Well, we talk about nature and degree, don't we, of the mental disorder, and if they have capacity, are they able to make decisions? Do they have insight? Do they accept that they have a mental health condition? And will they receive treatment? And it's usually if they are feeling suicidal and we are concerned that they will act upon those suicidal thoughts, or they even attempted suicide. And we know that suicidal behavior can be a manifestation of a mental health condition. And if we're concerned that they can be explicit and direct and say, I will do this again, I will kill myself. So they would meet but they're refusing to be admitted into hospital voluntarily. So if they are actually explicitly vocalizing that I will attempt suicide again, and they meet the diagnostic criteria for a major depressive disorder, but they are refusing to be admitted into hospital voluntarily, then sometimes we have to act on the best interests of the patient.
That's interesting. I think there's a lot of that clears it up actually in my mind, because I think there's a lot of stigma, like there is in all mental health, in particular around sectioning. But
there's a huge amount of stigma. I think there's a lot of people, they'll do everything they can to avoid being sectioned, and that includes suffering in silence. It might be that they can receive treatment in a more timely manner in the hospital environment, but they don't want to be admitted formally or informally because of the stigma of being admitted into a hospital or into a psychiatric hospital. When's the last time you went into a psychiatric ward and you saw get well soon cards? Go to the general hospital and the wards are full of get well soon cards. I've been working in psychiatry for a very long time now. I haven't seen a single get well soon card on a psychiatric ward. Definitely not on the psychiatric intensive care unit. That's for sure.
That's very interesting. Okay, I've been to a psychiatric ward a few times, but I can't say I've noticed that.
They're not very inviting places, unfortunately. No.
One other thing I want to have my touch on is maybe a bit left field from psychiatry, but it's around fibromyalgia. Now, obviously that fibromyalgia is obviously a chronic pain condition.
Yeah.
But I think there's a big link with mental health, because there's a big discussion about whether a trauma can obviously cause the mental health problem, but also can it lead to fibromyalgia. What's your experience with fibromyalgia?
My experience with fibromyalgia is that it's heartbreaking, because many, if not most of my patients with fibromyalgia feel like they've been fobbed off, and that because there's no biological basis, although recent research has revealed that there may very well be a biological basis, but even if there isn't, if you look how debilitating the symptoms are, it's heartbreaking. It's devastating. And for them to feel like they are being fobbed off, or that they are exaggerating, or that they are even fabricating, can be soul destroying. Even it really is. It's very upsetting. And so I think we have to validate, we have to be compassionate in the same way that we are towards persons with cancer, for example, or a health condition that has a biological basis. And now I think there is evidence that's starting to emerge that proves that there is a biological basis. But to emphasize, these people are clearly in distress, and they deserve compassion, and they deserve high quality care like everyone else. So I think not enough is being done. Not enough support is available. And that needs to change.
Great. I mean, do you think fibromyalgia has an underlying traumatic?
Oh yeah, 100%. Oh yeah, 100%. Yeah, I think most of my patients who present with fibromyalgia, they have like an unresolved trauma. Usually, I'm not saying that you have to go through this, but many have sexual abuse. As the female patients that I have are victims of sexual abuse. Yeah.
And just helping the trauma, obviously from a mental health point of view, help the symptom of fibromyalgia. I'd be interested to see if
to an extent. I mean, validation goes a long way. Just treating them like human beings, because many of them are being dehumanized, which is a disgrace to say the least. But some trauma-informed care does help, but we need to be holistic. They would also need to see, for example, a physiotherapist, get some input from a neurologist, for example, see an occupational therapist, and whatever aids and adaptations and benefits that they may be entitled to must be provided. So we need to be holistic for sure.
Great. Now, just the last thing that I say to all guests is just 3, quick fire questions. Just Professor Hankir's top 3 tips for fantastic mental health.
Self-care is non-negotiable. So whatever self-care is for you, and that unfortunately is a luxury, and my heart goes out to you. For example, 8 hours of sleep, that can be self-care for you. For me, like going for a run, like that's just non-negotiable.